A meniscus tear in the knee is one of the most common orthopedic injuries that exist, and it's also one of the most mistreated. So many patients are having unnecessary surgery for the meniscus. And also, so many patients are not having the surgery that they need. Here's how we make that decision.
Before we get into it, for anyone watching for the first time, can you introduce yourself?
Of course. I'm Dr. Leon Popovitz. I'm an orthopedic surgeon, and I'm the co-founder of New York Bone and Joint Specialists. I've been in practice for over 20 years, and my specialty is exclusively the surgery of the shoulder and the knee and sports medicine. My philosophy of care is that preservation is the key to longevity. I implement that in every doctor that works in our institution. Our goal is to preserve your vital tissues for a long life to come for you.
A patient comes in with a torn meniscus on MRI. What's the first thing you're figuring out?
First thing I would do is talk to the patient, find out how it happened, find out how old they are. Have they ever had problems with their knee in the past? Have they ever been told they have arthritis? Have they had a traumatic tear? Did it occur out of trauma? Then I would examine them, evaluate them. Do they have the full ability to straighten their knee? Are they able to fully straighten their knee, or is it locked or stuck? There are other maneuvers that we can do and tests that we can do to help us determine and confirm whether or not this truly is a meniscus tear.
How does the patient's age change your thinking?
Well, the meniscus is a crucial structure in the knee, and it has a lot of different functions. Two main functions is that it's a shock absorber in the joint, and it protects the articular cartilage, which is the lining of the joint. So we have top bone, bottom bone, femur bone, tibia bone. In between, we have the meniscus, which is this cushion of cartilage, and there's one on one side and there's one on the other side, medial and lateral. And then the ends of the bone have this kind of eggshell-like cartilage called articular cartilage. And the meniscus cushions and protects this cartilage. If that cartilage starts flaking off because the meniscus is no longer functioning, then the bare bone shows and you have arthritis. If the meniscus tears, it stops functioning, it stops protecting the knee from losing its articular cartilage, and arthritis may advance. So if someone very young, say in their teens or 20s or 30s or even 40s, tears their meniscus, one of the important things we have to consider is that we need to make sure that joint is protected for a long lifetime to come and many years to come. Well, as opposed to, for example, someone who is in their 70s or 60s or 80s and did not have a traumatic event, but had just felt a twinge in their knee and it's gotten worse with time, or you've had arthritis for a long time and gradually has developed arthritis. Those patients may have what's called a degenerative tear, and it's been shown that those kind of tears, patients actually do well with non-surgical treatment.
How does mechanism, sports injury versus bending down, change it?
So if it's a traumatic sports injury, where the knee kind of twists and the meniscus tears, then that tells us it's a traumatic tear, and that occurs more often in younger patients. And again, the issue of preserving their meniscus for many years to come comes into play. If it's somebody that tears their meniscus just from bending down or a little older, then we start thinking this is probably degenerative, where the meniscus has become a little bit more fragile, not as spongy, not as healthy, and it just kind of tore more easily as a result of minor trauma such as bending down.
Is the MRI always conclusive, or do you ever need to look inside to know?
The MRI is not always conclusive, no. It's not always 100%, of course not. We typically do not go in to look just for the sake of looking in. That's not something we do. It used to be done many, many years ago, but that's not something we do. So, for example, I had a patient that has all the clinical signs of a meniscus tear on physical exam and on history, but the MRI is not conclusive. I may consider doing the following. I may consider trying some conservative treatment for about a month and then following up, and then seeing if symptoms have improved, physical exam has improved, and determining whether the patient's unstable, because sometimes the meniscus, when it tears, a piece starts flopping around and it's like a marble getting stuck there, and you can roll on it and you can feel unsteady and buckle as a result of that. So if the patient's unstable, the patient has failed conservative measures and still has a negative MRI, then our suspicion rises that maybe the MRI was not completely accurate. Depending upon the symptoms, we could either do what's called an MRI arthrogram, where we inject some dye into the joint to make things much more visible, and then we can potentially do that, or then we can potentially proceed with an arthroscopy to look inside and see.
Can you explain the red zone and white zone, what that means and why it matters so much?
Yes, of course. So the meniscus in of itself has no blood vessels going to it. So the meniscus in the meaty part right here, has no blood flowing to it, and that's called the white zone. The periphery out here has blood flowing, and that's called the red zone. So a tear, for example, in the all white zone, in the meaty part here, has a much less likelihood of healing if we repair it, as opposed to a tear, for example, that may be here, that's in the red and white zone, where we can suture it and incorporate a lot of the vasculature. Because again, for healing, it's very important that we have approximation, bringing two things together as close as possible, good fixation, making the approximation solid, so there's no movement, and blood flow. All the healthy nutrients for healing needs to come. So if we try to reapproximate a white-on-white tear and make the fixation great, but there's no blood flowing to it, won't heal, or at least the likelihood is very small.
Is there ever a case where a white tear zone is worth trying to repair?
That is a debatable issue. More and more people, with the advancement of new fixations that are really very strong, being a little bit more daring and repairing some of the more white-on-white tears. It is particularly more potentially effective if the meniscus repair is done during an ACL reconstruction, because when we do an ACL reconstruction, we do a lot of drilling in the bone, and blood, all the nutritious stem cells come out with the blood from the actual bone marrow, and that promotes healing. So there's a higher likelihood of healing of a meniscus repair during an ACL reconstruction as opposed by itself. But the short answer is that there's a dramatically, it's unlikely and uncommon to repair a tear that's exclusively in the white area.
Can you tell the zone from MRI, or do you need the arthroscope?
We can make an educated determination, but unfortunately, definitively, we don't know until we're in the operating room doing the arthroscopy and probing the actual meniscus. So we actually need to feel it. So we're in the operating room, the tear may have looked somewhere in this area here, but when we're in the operating room, I'll put a probe, an instrument, to feel exactly the tear, and I'll find that it actually extends all the way back to the blood flow. And then wonderful, because now we can preserve that meniscus instead of taking a portion of it out.
What does a bucket handle tear mean, and why is it sometimes urgent?
So a bucket handle, there's different types of meniscus tears, and it's based on the pattern of the tear, how it looks. But a bucket handle tear is essentially when the entire meniscus is torn, and then it displaces out of where it should be and is sitting usually here in what's called the intercondylar notch. And if the meniscus is in its natural state, you can extend the knee fully. But if the meniscus is displaced and sitting like that, then you can't straighten your knee. And that's called a locked knee. If the knee is locked for too long, then the muscles start contracting, and then even if we do surgery, say weeks or months later, potentially, we can fix potentially the meniscus, but the ability to straighten may be compromised because the muscles have already gotten so contracted. Very often a bucket handle tear is a bit of an orthopedic urgency. We try to address that tear very promptly. Aside from the fact that the patient has extreme difficulty walking because their knee is locked. The reason why it's called a bucket handle is because when the meniscus is in this position, it looks like the handle of a bucket.
How do you decide between repairing the meniscus and removing part of it?
I always go into the operating room and I instill this into every doctor in our institution at New York Bone and Joint to always be ready and prepared with the goal of repairing the meniscus, repairing whatever we're going to proceed with or reconstructing if necessary. But in terms of the meniscus, I always go in with the goal and intention and to repair the meniscus. If for some reason we find that the tissue is just not amenable to repair, and unfortunately, we wouldn't be able to if it's just in the white zone or it's in the periphery of the white zone, that there's absolutely no blood flowing to it. We're not doing the patient any good, because if I repair it, fixation may be good, I can approximate it well, but if there's no blood flowing, the patient's just going to come back in a few months and say, my pain has returned because the meniscus did not heal. So I have this conversation with my patients always before the surgery. I make them understand that, based on the MRI, it may or may not look like it's repairable. And for example, if the MRI looks like it's repairable, we say we're going to go in there with the goal of repairing it. But I have to make sure you understand that sometimes the tear is in a place that's not repairable. And then what we'll do is we'll just trim only the unstable portion so as to minimize any loss of cartilage. And then sometimes we have a patient that may not look like it's an repairable meniscus. But I explain to them, sometimes that's not completely accurate. Very often it's not. And because you're young and active and have many years to go, we're going to go in there with every effort and intention to repair that meniscus.
What do you tell a patient who really wants to save their meniscus, but repair isn't technically feasible?
I'm honest with them. Especially if it's degenerative. There's a lot of debate. So some people may say, well, even in degenerative tear, if you go in there and you repair it, at least you'll slow down that progression. That's debatable because the cascade has already started. Arthritis is a cascade, and once it starts, it's difficult to stop. We're actually doing clinical animal studies right now. New York Bone and Joint specialists are in methods to slow that cascade down. But as of now, that has not been fully discovered. So once that cascade starts, even repairing the meniscus once the arthritis has progressed probably would not be of benefit. And very often, those kind of degenerative tears actually do well with non-surgical treatment, physical therapy, potentially an injection. Those patients we treat non-surgically, we try conservative treatment, and if after, say, a month or two, they're still in a lot of pain, particularly if they're feeling unstable or they're locking, the pieces keep getting caught in there like a hangnail. For those patients, then we do proceed with surgery. But that's a minority. Most these days, the majority of patients that we go in for meniscus surgery is for the intention of repair.
Is it ever truly okay to leave a tear alone?
If it's a degenerative tear and the patient has the beginnings of arthritis and they're not feeling unstable or locking and they've tried some conservative treatment and they're feeling like they can live with it, then that's perfectly fine.
What happens to the knee long term if too much meniscus is removed?
Arthritis is the short answer to that. So the meniscus is the protector against arthritis. It's a shock absorber and it distributes the load. So if you're bouncing, walking on hard surface, it's a shock absorber, but it also distributes the load. So there's not one area that's getting pounded or feeling the brunt of all that force. So if the meniscus tears, the function is lost and the protection against arthritis is lost and the protection of this articular cartilage is lost, starts flaking off, bone shows, and that's arthritis.
Is there a point of no return where the damage is done?
Unfortunately, yes. It depends upon the amount of articular cartilage lost for the most part. It's also determined based on the angulation. So if the patient on a standing x-ray has his or her knee very bent and crooked all the way, that is an indication the articular cartilage is significantly lost on that area. But really the focus is that if you've lost diffusely the majority of your articular cartilage, we're not going to be able to get that back for you. If you have isolated spots of lost cartilage, so for example, it's just an area here or an area there and a meniscus tear, that's a different story. Most certainly what we can do is we can repair the meniscus to improve pain and protect the remainder of the articular cartilage, and then we can do cartilage rejuvenation procedures for that spot. We can't do the rejuvenation procedure if diffusely all the articular cartilage is lost. But if there's a spot, isolated spot, then we can either do what's called a microfracture procedure, where we drill little holes in the bare bone that's showing, and then the stem cells start coming out, they scab over and create what's called a fibrocartilage, which is a combination of scar tissue and cartilage. It's not as good as the original cartilage, but is as close as it gets. And other options are we can transplant cartilage. We can take cartilage from the periphery where it's not as used, there's no real weight that's bared on there, and we can transplant it into that area.